Hi everyone, this is Dr. Cohen, and I am here to give you a brief insight about the myofunctional and orthopedic appliances. And I'm glad to be a part of your preparation journey. But since this is a very vast topic, I'll be quickly brushing up over the topic. While the slides contain all the important points, I would request you to make sure that you make notes of whatever is jotted in the slides, but rather the session will be a quick brush up. So, because it's an entire vast topic. With no further delay, we'll just get into the topic. So in today's session, we'll be seeing about the introduction, the classification of functional appliances, basis of functional appliance therapy, treatment principles, components of functional appliance, mode of action, case selection, functional appliance of different types, whether it's removable or fixed, and then we have orthopedic appliances. Then we have a quick recap over the session. So moving on, what is functional appliance? A functional appliance is an appliance which utilizes the natural orofacial muscles forces to influence the dentofacial growth, unlike mechanical appliances that generate active forces. Mechanisms include the transmission, elimination, and guiding of muscle forces to correct aberrant growth and function. So these are basically used in class 2D1 cases or in class 3 cases of growing children. So this could be of removable or passive. There is the removable and passive type. It can also be fixed based on the depending on the case what we are doing. And dating back to history, in 1879, it was Norman Kingsley who positioned the mandible forward. In 1902, we have Perry Robin who introduced the first removable appliance, which is a monoblock appliance. And in 1905, we have Emil Herbst who developed a fixed pin and tube appliance. In 1908, we have Viggo Anderson who created the activator, which was later modified by Carl Hoppel. And then we have in 1966, Rolf Frankel who introduced the functional regulators. And later on, many adaptations followed after they got renamed with their developers. And then the classification. The classification is basically of various types. First, we have the generalized classification, and then we look into the classification by Graeber's, classification by Profit, and then the classification based on force transmissions. So in the generalized classification, it is of various types, that is removable functional appliance, fixed functional appliance, both removable and fixed functional appliance. A classic example for removable functional appliance would be the activator, binator, and triangle. For fixed functional appliance, it is Herbst, Jasper jumper, Churro jumper. For both removable and fixed, it's twin block and Herbst. Again, as mentioned earlier, this could be based on the type of case we select. So based on depending on the case, it could be a twin block, a fixed twin block, or a removable twin block. And same with the Herbst. Then it's semi-fixed, removable, fixed. For this, we have a classic example of Reynolds and Barr's appliance. Then in the classification by Graeber, these are grouped into three categories, group A, B, and C. In group A, we have teeth-bone supported appliances. In group B, we have teeth and tissue bone supported appliances. And in group C, we have vestibular position appliances. In group A, a classic example would be Catalan's appliance or inclined plane. In group B, which is tooth tissue bone supported appliances. Here we have activator, binator, and lip bumper. For group C, which is vestibular positioned appliance, we have Frankel appliance and vestibular appliance. In the classification by Profit, again, we have myotonic appliances, myodynamic appliances, tissue-borne passive appliances, tissue-borne active appliances, and then we have functional orthopedic magnetic appliances, which is nothing but FOMA. So in myotonic appliances, we have classic examples of activator, binator, Herbst appliance, and in myodynamic appliance, we have elastic open activator. Then we have Bimler's appliance, modified binator. In tissue-borne passive appliance, we have, in tissue-borne passive appliance, we have Frankel functional regulators. In tissue-borne active appliance, we have lip bumper, oral screen. So this is a classification given by Profit. Next is a classification based on transmission of force. Again, this is categorized into three groups, group 1, 2, and 3. In group 1, we have inclined planes. These transmit the muscle forces directly to the teeth. And in group 2, we have the appliances which reposition the mandible. So classic example of this could be activator and binator. In group 3, we have appliances that reposition the mandible but operate in a vestibular region. A classic example for this would be Frankel and vestibular screen. The functional basis or the basis of any functional appliance therapy is based on three main theories. One is a functional matrix theory, the other is a servo system theory, and the other is the growth relativity theory. Let's look at the first theory, which is the functional matrix theory, which is given by Melvin Moss in 1962. So in this theory, he states that the growth and development and maintenance of skeletal tissues, that is bones and cartilage, are secondary responses to the functional demands from surrounding soft tissues. So this means that bones do not grow on its own or independently, but adapt to the functional needs of the skeletal structures. So the key principles here are soft tissue drive the bone growth, and then we have the functional matrix versus skeletal unit, and then the bone growth is secondary and adaptive. So in the first that is soft tissue drive bone growth, we see that any demand of the functional soft tissues, that is the muscles, ligaments, periosteum, they drive the growth of the bone. And in the functional matrix, that is the soft tissue and spaces surrounding the bone, they influence the growth of the bone. And in bone growth, that is secondary and adaptive. Here it states that the muscles, spaces, they all influence the change or they reshape the underlying skeletal structure. Next, we have two types of functional matrices. One is a periosteal functional matrix and the other is a capsular functional matrix. In periosteal functional matrix, it is again the soft tissues. A classic example for this could be the masseter muscle, which influences the ramus height of the mandible. And the second is the capsular functional matrix. Here, the spaces influence the growth of the bone. A classic example for this would be the expansion of the brain, which influences the growth of the cranial vault. So to summarize, we can say that bone is a follower, but not a leader, and skeletal changes are in response to the soft tissue functions. Next, we have the servo system theory. This is an absolute feedback loop mechanism. So this was given by Alexander G. Petrovic. So here he states that the functional appliance influence the mandibular growth through neuromuscular and hormonal mechanism. It regulates the growth of the mandible in a controlled loop, a feedback loop mechanism. So here what happens is that when the mandible is advanced forward, this theory states that when the mandible is advanced forward, there is a stretch in the lateral pterygoid muscles. Once there is a stretch or hyperactivity in the pterygoid muscle, this creates a tension in the retrodiscal tissue. So once there is a tension in the retrodiscal tissue, the proprioceptive receptors or nerve endings get activated. So once the proprioceptive receptors are activated, it sends signal to the central nervous system, and in the central nervous system, it activates the pituitary gland to secrete the stomatomerin or growth hormone, which stimulates the growth of the condyle. So this is a feedback loop mechanism where the positioning of mandible influences the hormonal regulation. So why it is important in our functional appliance therapy, or what is the role of this theory in our functional appliance? It stimulates the growth, enhances the condylar growth, and redirects the growth. So what is its clinical implication? It explains why the functional appliance can modify the mandibular growth. It highlights the importance of neuromuscular activity in jaw development, and it suggests that myofunctional therapy can influence the jaw posture and TMJ adaptation. To summarize, again, we have the feedback loop mechanism. There is lateral pterygoid, neural feedback, and this release of growth hormone, which influences the condylar growth. Then we have the growth relativity theory. This was given by Woodruff et al. So in this theory, he proposed that it explains how the mandible responds to functional forces, particularly during orthodontic and orthopedic treatment. So he suggests that mandibular growth is not just limited to the condyle or condylar adaptation alone, but it involves a complex network of viscoelastic forces that influence multiple bone structures in the craniofacial region. So the key concept of the growth relativity theory is that mandibular advancement stimulates growth. That is, when the mandible is advanced forward, again, there's a tension in the retrodiscal region, and this creates a transmission of the force. So its main growth relativity theory is mainly based on the transmission of force and in the viscoelastic system. So what happens here is that earlier like servo system theory, which focuses mainly on the condyle, this theory is little different. It focuses that the bone formation occurs at multiple regions, at multiple areas due to the transmission of forces. So example for this would be the articular eminence. So any tension in the condylar region or any stretch in the muscle region, not just it readapts the condyle or remodulates the condyle, but it also forms bone near the articular eminence. bone remodeling near the articular eminence, and the TMJ and surrounding tissues behave like viscoelastic system, meaning the forces applied in one area is spread throughout the joint and influences the distant sides. So this brings about a change even in the glenoid fossa. So again, to summarize, this theory helps in advancing the mandible, and then it activates bone formation at multiple sites and influences the entire TMJ complex. So clinical implications of this theory is that it supports the use of functional appliance in mandibular advancement therapy. It explains why bone remodeling occurs at multiple sites and not just at the condyle, and it reinforces the idea that growth is influenced by external forces, not purely by genetic reprogramming. So this is a functional appliance overview, where again it explains the same thing of the stimulation of the growth hormones, and then again how the change occurs at the subperiosteal level, which leads to the increase in the length of the bone. Then the treatment principles of functional appliance. In this, we have force transmission and force elimination. So in the first force transmission, we can see that because of the force, there is a compressive stress and strain occurring in the skeletal and dental structures, which leads to primary alteration in the function and secondary adaptation in the form. So the principle applies to most fixed and removable functional appliances. So there is direct force transmission and indirect force transmission. Direct force transmission influences directly on the skeletal and dental structures, whereas indirect force transmission appliances work by repositioning the mandible and redirecting their growth. So for the direct force transmission, we have classic examples like lip bumper and oral screen. And for indirect force transmission, we have activator, binator, and Herbst. For force elimination, these are the appliances which relieve the unwanted or excessive neuromuscular forces which cause the malocclusion. A classic example for this would be Frankel, Frankel appliance or functional regulators. So to summarize, force transmission applies force to alter the function and form, and force elimination removes abnormal influence to restore the normal growth. So the components of functional appliances include bite plates, shields or screens, construction or working bites. So the bite planes, these also act as guiding planes. So what the bite plane does is that these are acrylic plates, acrylic planes. So they disocclude the posterior by 2 to 3 mm, leading to the eruption of the posterior teeth. This is called differential eruption. So what happens in differential eruption is that it can either stop the eruption of the anteriors, or it can intrude the anteriors, and the posteriors are extruded. So because of this difference in eruption, it is called differential eruption. And then we have guide planes which redirect the growth of the mandible. Then we have vestibular shields and screens. So these vestibular shields and screens, they work basically on the equilibrium theory. So they help in relieving the unwanted forces, or they block the external forces that allow the malocclusion to occur and helps in a more natural growth. So example for this could be again Frankel and lip bumper. Frankel eliminates the force, whereas lip bumper transmits the muscle force. And then we have the construction of working bites. These are maxillomandibular relationships which are recorded, and they help in fabrication of the appliance. So the mandible is displaced in sagittal, vertical, and transverse plane. So the effect of construction bite is that they trigger the myotactic activity, and then they alter the jaw repositioning. To summarize again, we have bite plates, screens, and shields. And the construction bite plates control the eruption and overbite reduction, and shields and screens, they block the unwanted muscle forces, allowing natural growth. And in construction bite, they define the maxillomandibular relationship and influence skeletal adaptation. So mode of action, again, the mode of action is of 3 types. We have the orthopedic changes, we have the dentoalveolar changes, and then we have the muscular changes. In orthopedic changes, we can see the stimulation of the condylar growth, the restrictive influence on jaw growth, there is a maxilla especially. Then we have the changes in direction of the jaw growth. In dentoalveolar changes, there is selective force application via guide planes, where the guide planes do corrections in the sagittal, transverse, and vertical planes. In the sagittal, they correct the tipping of the tooth. In the transverse, they expand the arches. In the vertical, there is selective eruption. The muscular changes follows after this. So in the muscular changes, we can see improved orofacial muscle tonicity. And then there is growth modulation, skeletal changes, where there's increase or decrease in the jaw size, change in the spatial relationship between the jaws, alteration in the direction of the jaw growth, and acceleration of desirable growth. So to summarize, the orthopedic changes stimulate or restrict the jaw growth, changes the jaw direction, jaw growth direction, especially. And in the dental alveolar changes, we can see the modification in tooth positioning in the sagittal, vertical, and transverse plane. Sorry. So in the muscular changes, we have improved muscle tonicity, which modulates the jaw growth. So case selection. So in case selection, again, we have certain considerations, the traditional versus modern indications. So the classic indication would be a class 2 Div1 case. Of course, it is given in class 3 as well, but we focus mainly on the class 2 Div1 cases. And then the age consideration, functional appliances are to be given in patients with growth potential, especially in the late mixed dentition, that is 10 years to the pubertal growth phase. And then the dental considerations, if there is any alignment of any crowding in the dentition or in the arch, we first need to rectify the alignment, and then we go with the functional therapy. Then there is also skeletal considerations, where we see for the saddle, articular, and gonial angle. So when the saddle angle is increased, it is not ideal for the functional therapy. And the articular angle, when it is increased, it is ideal for retrognathic mandible, that is class 2 cases. When it is decreased, it is not ideal because the mandible is prognathic in such a case. And then the gonial angle, acute gonial angle or a small gonial angle is favorable for anterior mandible positioning. Large gonial angles are completely contraindicated. Then to sum up these angles together, they are called the Bjork angle. So here we can see that if it is less than 360 degrees, it is favorable. It indicates that it's a horizontal grower. And then if it is greater than 360 degrees, it indicates that the patient is a vertical grower. So the functional appliances are contraindicated. Here you can see the images of saddle angle, articular angle, and gonial angle. So next we have the anterior and posterior facial height, which is a Sella-Gonian and Nasion-Menton ratio. So if it is less than 62%, it indicates a vertical growth, which is contraindicated. And if it is greater than 65%, it indicates horizontal growth. And low angle cases where the FMA and mandibular plane angle are compared, decreased FMA are favorable and increased FMA are not ideal. Then we have the convergent jaw bases, which are very much ideal for functional appliances. Then again, in class 2 cases with upward or anti-clockwise rotation, it is very much suitable for a functional appliance therapy. Then skeletal class 2 malocclusions, we have moderate to severe. Moderate to severe cases respond well. Then we have short retrognathic mandible. Then prognathic maxilla, they are best treated with orthopedic appliances like headgears. Then in class 2 Div 2 cases where we align the anteriors first and then we go for the functional correction. Checking the video is very much important, and periodic recording of these, video positive using photographs is very much essential. The recording is done using Ricketts cephalogram or clinical mandibular positioning, that is clinical mandibular advancement. If there's an improvement in the profile, the patient is a good candidate for functional appliance therapy. So this is an overall flow chart of the various types of functional appliances which could be used for the patient based on the need. Again, these are the indications. These are the indications and contraindications. Yeah, now it's clear. So these are the indications and contraindications for functional appliance therapy. All this is previously mentioned, so you can just brush it up. Then the different types of removable functional appliances. We have the vestibular screen or oral screen. This was introduced by Newell in 1912. So it has a thin acrylic shield. This shield helps in the transmission of the forces, muscle forces. Again, there is different modifications of these appliances. So it contacts only the most protruding anterior teeth, and if no teeth are proclined, some refer to it as vestibular screen instead of oral screen. So only when there is a contact with the teeth, it's called an oral screen, and if there is no contact with the teeth, then it is called a vestibular screen. Here you can see the different modifications where a metal ring is introduced, then you have a lingual shield on the inner side. So these are the different modifications of these vestibular screen. So the indications are habit correction appliances, muscle training and strengthening, for correction of mild class 2 malocclusion, for retroclination of mildly proclined anterior teeth. Then we have precautions that these cannot be given in nasal obstruction patients. So the mechanism of action, again, it is based on force application and force elimination. Force application transfers the perioral muscle forces to the proclined incisors, and in force elimination, you can see there is unwanted forces, buccal forces, and these shields prevent in removing the unwanted forces. And then we have the mechanical, it acts as a mechanical barrier for habit correction. Then we have mild class 2 D1 correction, and then we have muscle tonicity improvement. So the management of these vestibular screens is that it's a full-time wear at night, especially during the daytime. We wear it for only, we advise the patient for only 3 to 4 hours of wear. The lips should be closed tightly to maintain a proper lip seal. Tissue care should be taken, especially near the sulcular or frenal regions. They should be relieved. And then these are the modification, Holt's modification with oral screens, and we have the Krauss double oral screen. Then modification for mouth breathers with initials holes, and then gradually we close the holes and then adapt the patient to nasal breathing. You have an overview on what are the different aspects of modification. Then we have an overview about lip bumper. So again, these are modified vestibular screens for muscle force application and elimination. So in the upper arch version is called a Danholz appliance. The uses of lip bumper are its habit breaking. It helps in the alignment of lower anterior teeth, especially used in case of hyperactive mentalis. It prevents the lip trap, especially, and tilts the lower anteriors forward, increasing the arch length. So then it also acts as an anchorage saver. It provides muscle anchorage. Then we have distalization appliance. This acts as a distalization appliance. It can distalize the mandibular molars using springs or loops. These are best used before the eruption of second molars. They also act as space regainers in the interceptive orthodontics to regain space lost due to early loss of deciduous molars, preventing the mesial drift. So this is the structure of the appliance. So here we can see the appliance, which is made of the hard SS wire, and then it is soldered to the molar bands. And then we have an acrylic portion in the front region or in the anterior region to relieve the muscle forces or to transmit the forces, depending on what type of action we need. Then we have activator, which is a monoblock appliance. It's also called Norwegian appliance. So briefing its history, as told earlier, in 1879, Kingsley came forward with the vulcanite palatal plate, and then Perry Robin came and he developed the monoblock appliance, which is single block appliance. It's used for mandibular advancement and airway protection in glossoptosis cases. Then in 1908, we have Viggo Anderson, who created the loose-fitting functional appliance. So you can see it was further modified by Carl Hoppel to form the functional jaw orthopedics. So they named it activator for its stability to stimulate muscle forces, also known as Norwegian appliance due to its development in Norway. So again, these are the indications: growing children and their favorable growth potential is very much important. And then again, well-aligned maxillary mandibular arches. You have class 2 D1, class 3, and open bite cases. The advantages is that it utilizes the natural growth potential, hygienic and easy to maintain, minimal chair side adjustment, and more cost efficient. Disadvantages of activator therapy is that it requires high patient compliance and it's bulkier. So these are the components of an activator. There it has a maxillary component, mandibular component, and an intraocclusal component. It has a labial bow, and then incorporation of expansion screw can also be done based on the case, depending on the case, if we need expansion or not. So the mode of action is again myotactic reflex activation, restriction of the mandibular growth, and forward positioning of the mandible, and distalization of the molars. Then the activation of this appliance is done by selective trimming. It's having a vertical control and a horizontal control. Vertical control influences the intrusion extrusion, and sagittal control is protrusion retraction and molar distalization. So this is done by loading the acrylic or by removing the acrylic in certain regions. And the activation of labial bow also helps in retrusion of the maxillary incisors. So the patient management and appliance wear is that in the first week, it's 2 to 3 hours per day. In the second week, it's an overnight wear within 1 to 3 hour wear during the daytime. And in the third week, we evaluate the fit and trimming of the appliance is done. Checkups for every 4 weeks is done. So the modifications of activators are Woodruff's activator, bow activator, cybernator, Karwatsky's modification, propulsion, cutout or plate-free activators. Then we have the elastic open activators. So here you can see what are the different activator modifications. So moving on, next we have the binator. So this was given by Balters. He basically believed on the principle of equilibrium based on the tongue pressure. So he believes that the tongue pressure is very much essential for the arch expansion. It influences the oromuscular, it distributes the oromuscular forces, and it helps in the development of dentition in a proper manner. So this is the main difference. Here we have an omega loop. There is no roof as in the activator. Instead, we have an omega loop. Then we have a labial bow only in the lower arch, lower dentition. So while in the activator, it is given in the both or mostly in the upper. So here it has been given only in the lower. Again, the activation is similar, but selective trimming, we can modify the growth. So this is with binator, a brief overview. Again, for binator, it is standard binator. For class 3 corrections, we have reverse binators. And for open bite cases also, we give. Now we have Frankel appliance, which are functional regulators. This was given by Rolf Frankel in Germany. So again, this is based on, it's a full-time delivered appliance where the muscle forces are selectively transmitted or eliminated as Frankel 1, Frankel 2, 3, based on different needs, different malocclusions. There are different types of Frankel appliance. So the Frankel philosophy is that it has the vestibular action. It influences the dentoalveolar growth by modifying the muscle function, and the muscle influence, it controls the buccinator mechanism and orbicularis oris to aid the expansion. So here you can see the various muscles and their influence in the dental arch. So again, it has vestibular components, acrylic component and wire components. These are the vestibular components which facilitate in the expansion. One is to relieve the force, the other is to exert force, the other is to transmit the force of the tongue, transmit the force or, transmit the pressure from the tongue. So these are the various components, functions of various components in the appliance. So again, the lip pads, upper lip pads are present in Frankel 2, Frankel 3, whereas it is absent in Frankel 2. Then we have the wire components. In the wire components, we have upper labial bow in Frankel 1 and 2, and lower labial bow only in the Frankel 3. Then these are the various wire components: lingual bow, labial bow, then crossover bow, palatal bow. There are different kinds of bow. So Frankel 2 stabilizes the appliance, prevents lingual tipping of the anteriors. So the wire component, there is a lingual bow in Frankel 2, stabilizes the appliance, whereas the lingual bow in the, or the protrusion bow in class Frankel 3 stimulates the forward tooth movement. So these are the other components, which are lingual springs and canine loops. Again, they have the same function in guiding the tooth eruption and guiding the teeth alignment. So the mode of action of Frankel appliance, again, it affects the dentoalveolar structures, increased transverse and sagittal space, increased vertical space, and sagittal correction. Sagittal correction is by lip pads, and proprioceptive effect comes from the lip pads. And then we have the increased vertical space, which influences the appliance, remains free from the maxillary posterior teeth. Selective eruption occurs. Then the increased transverse and sagittal space, where the buccal shields and lip pads eliminate the perioral muscle forces. So muscle adaptation, muscle function adaptation, the pads and shields stimulate the perioral muscle pull, which which helps in the bone formation. Then we have the periosteal bone formation. Additional effects of Frankel appliance is that it also acts as an exercise device. Hence, it's called oral gymnastics. So it helps in talking, reading, swallowing, and tightly holding the appliance. So the difference between Frankel 1 and 2 is that Frankel 1 lacks the lingual shield, lingual springs, lingual crossover wires, and the upper lingual wire. This is Frankel 3, where we can see the buccal shield 3 mm away from the maxillary posterior structures, which contacts the mandibular apical base, eliminates the buccinator forces, and stimulates the bone growth from. And the protrusion bow helps in the protrusion of the incisors. Frankel 4 is given in open bite bimaxillary protrusions. So Frankel 5 is given in long face syndrome, it incorporates a headgear and posterior acrylic bite blocks. So the construction bite, again, it's taken with by putting the both the jaws and the dentition in edge-to-edge relationship. Manual advancement is 4 to 6 mm, where the insert is put in edge-to-edge relation. The posterior clearance is to 2.5 to 3 mm in Frankel 1 and 2, and it's 1 to 2 mm in Frankel 3. Again, we do selective trimming. The wear time is that in the first week, it's 2 to 4 hours per day. After 3 weeks, it is 4 to 6 hours, and after 2 months, it's a full-time wear appliance. So then we have the twin block appliance. It was introduced by William Clark. So this one again a very comfortable appliance because it is a two acrylic block appliances, and it helps in other movement of the oral cavity, that is the speaking freedom. There's freedom of movement as such. So there's speaking, eating, and oral functions. Everything could be done very easily because of its two-piece appliance. So it mainly works on the principle of guiding the growth. That is, it has an inclined plane with various degrees of angulation. That is, it initially began with 90, but then it got improvised to 45 and 70. So these are the appliances. Here you can see the 45-degree, 75-degree inclined planes. So the components of twin block, again, we have the upper plate, lower plate, then incorporation of, jack screws for expansion can be done. And then you have the different clasp, delta clasp, arrowhead clasp, and all that. So again, here you can see the modifications with the angulations. 90 degree, then we had got it to 45, and then it was finally brought to 70 degrees. 70 degrees is considered to be standard. Still, we can use 45 degrees in patients who struggle to position the mandible forward. So case selection is as told earlier as any other functional appliance. So the bite registration here, it is placed, the mandible is placed forward, advanced by 5 to 7 mm, and the vertical bite opening is 3.5 mm in the premolar region. So for growing children, it's edge to edge with 2 mm of clearance. There is in large overjet, partial correction is done in the beginning. Then orthopedic traction, we have severe skeletal discrepancies. So used in maxillary prognathism and mandibular retrognatism cases. So if you're planning to give an extraoral traction, then it could be of around 200 to 300 grams per side. That is 8 to 10 hours per day. Then we move on to fixed functional appliances. Where there is no patient compliance, we go for the fixed functional appliances, or poor patient compliance, you can say. So the first one would be a Herbst appliance. So this Herbst appliance was popularized by Pantris in 1979. It's a fixed functional appliance with piston and tube system. Here you can see the piston and tube, the axle, screw, tube, plunger. So this is used as a component in advancing the mandible. So the short-term duration is 6 to 9 months. Short treatment duration is 6 to 9 months. It is ideal for late-stage growth patients with minimal residual growth potential. So it affects like any other functional appliance. It also has a benefit on chronic snoring and mild, moderate over obstructive sleep apnea cases. So the types of Herbst appliance could be a banded Herbst appliance, bonded Herbst appliance. The treatment effects of class 2 correction, overjet reduction, and restriction of sagittal maxillary growth. Then the advantages are limited effect. Advantages that effective for limited growth potential period. That is, the patient has already crossed the active growth. Then even in the limited growth potential, we can give such cases. The disadvantage could be breakage of the appliance or gingival growth, gingival health condition concerns. Then we have the Jasper jumper, which is again similar to the Herbst appliance, but this is a spring-based appliance. So it's a vinyl-coated spring. It is covered by opaque polyurethane for hygiene and comfort. It's available in 7 sizes. It's basically a telescopic mechanism. So in mechanism of action, we measure the distance meson to the upper faceboard tube to the distal aspect of the Lexan ball, that is the mandibular canine. Then we select the force module length based on this, that is a measured length plus 12 mm. Upon occlusion, the force module curves, exerting mesial force on the mandible and distal force on the maxilla. So the indications are again class 2 malocclusions, and the contraindications are minimal buccal vestibular space. So these patients are contraindicated. So to conclude, myofunctional appliances play a key role in interoceptive orthodontic influence. In interoceptive orthodontics, especially they influence the skeletal growth modulation, muscle training, and dentoalveolar modifications. Selection factors are growth potential, patient compliance, muscular imbalance, aesthetic considerations, and cost effectiveness. So next we move on to the orthopedic appliances. So brief introduction. Orthodontic therapy is basically dentoalveolar malocclusion correction. Orthopedic is basically skeletal discrepancies correction of skeletal discrepancies, which in turn corrects your dentoalveolar malocclusion. So orthodontic forces are light forces, 50 to 100 grams. Orthopedic forces are greater than 400 grams. So the philosophy of orthopedic appliance is extraoral force. So they help in growth modification, camouflage treatment, surgical correction. So again, the treatment criteria depends on severity, age, and diagnosis. So the basis of these orthopedic appliances is it utilizes higher forces than minimum force and duration required for skeletal changes. The force exceeds the dental structure threshold, but alters the skeletal growth. So the amount of force, minimum force which can be given is 400 to 600 grams per side, and the maximum force is 800 to 1200 grams per side, that is 2 to 3 lbs. And then we have high forces which cause skeletal change and not the tooth movement. So this is headgear. We now look into the topic of headgear, where we can see it's the most common orthopedic appliance. It stops the forward maxillary growth. You have the different combinations of the sagittal relation, normal sagittal relationship, class 2 base, and then class 2 base normal maxilla with retrognathic mandible, class 2 skeletal basis with maxillary prognathism and retrognathic mandible. So these are the different combinations of class 2 patterns which we can have. So the function is to stop the forward maxillary growth and to distalize the maxillary molars and skeletal. So indications are to used in class 2 cases due to prognathic maxilla, and in cases which needs anchorage using extraoral forces. So the duration of wear is 12 to 14 hours is recommended. So here again, we can see based on the anchorage we take, it could be classified into different types. That is occipital anchorage, cervical pull, outer bow adjustments can be done, or a vertical pull headgear. So based on the anchorage we derive, with these are given the terms. Then the timing of force application. So a prepubertal growth spurt with SMI 4 to 7 and Fishman index is the best timing for headgear appliance. So the common orthopedic appliances are headgear, face mask, and chin cup. The combination to compare the orthopedic and orthodontic forces, it is just that orthodontic forces are light forces and orthopedic forces are heavy intermittent forces, which modify the skeletal structures. So again, the main components, principles of force application in headgear is the center of resistance, the force, the direction of force, the center of resistance, and the point of origin of force, and the point of attachment of force. So for the maxillary dentation, the center of resistance, as we all know, it's in the furcation area near the first molar. For dental arch, it is between the premolar roots, and in the maxillary skeleton, it is in the center of resistance between, center of resistance is believed to be in the posterior zygomatico-maxillary suture. So anchor sites could be neck, occipital region, and parietal bone. So the effect on different headgear type is that occipital headgear produces a superior distal force, cervical headgear produces an inferior distal force, high pull headgear exerts a vertical pull on the maxilla. So the point of attachment of the force, again, there is a hook on the distal end of the outer bow, and this helps in the attachment. So here we can see the cervical headgear, where the anchorage is taken from the nape of the neck. So the force direction is inferior and posterior. The effect of force vector is that maxillary molar extrusion and distalization or distal translation occurs. It creates a counterclockwise rotation of the maxilla and a clockwise rotation of the mandible. Then the vertical effects, again, we can see small extrusive forces and large clockwise moments cause downward and backward rotation of the mandible. So indications are low mandibular angle cases with deep bites, as it increases the lower facial height, and suitable for short face class 2 protrusion cases. So this is the cervical headgear. And then we have occipital headgear, where the force direction is distal and superior. It helps in intrusion and distalization. The earlier was extrusion and distalization. And then here we have the combination pull headgear. The combination pull headgear is again, the force direction is distal and slightly upwards. So based on the force line, above the force line, it produces posterior force, counterclockwise rotation, and intrusive effects. And below the force line, it causes posterior and superior force, which causes clockwise rotation. So indications are best for class 2 malocclusion with no vertical problems. It helps to prevent the anterior migration of the maxillary teeth. Then we have the high pull or vertical pull headgears. So here the direction of force is perpendicular to the occlusal plane. So it causes counterclockwise rotation of the maxilla and intrusion of the anterior teeth. And clockwise rotation is seen when the force is directed posteriorly. Indications are anterior vertical maxillary skeletal axis and gummy smile, and it is useful for long face class 2 patients. So here you can see the high pull or vertical pull headgear. Asymmetric headgears, based on which side you need the class 2 correction, the asymmetric headgears are given. So the clinical applications of headgear is that orthopedic force effect. In the orthopedic effect, the maxilla is connected to the cranium by different sutures. So these are the different sutures: frontal, zygomatico-frontal sutures, maxillary sutures, temporal, zygomatico-temporal sutures, pterygopalatine sutures. So based on these sutures, the cranium maxilla is connected to the cranium. So headgear creates a force which compresses these suture, and as a result, it restricts the maxillary growth, allowing the normal growth of the mandible. Then the force requirement to stop the maxillary growth is 1,200 grams, and to redirect the maxillary growth, we have the growth for about 600 to 800 grams of force is needed. So for best results, it is to be worn 12 to 14 hours per day for optimal force, especially in the pre-adolescent years. So the dental effect is the distalization of the maxillary molars, extrusion of the molars, depending on the line of the force application, and then intrusion of maxillary anterior teeth when used with removable appliance. To avoid skeletal changes, the force magnitude should be kept below 400 grams if we need it. These are the uses: growth modulation, anchorage augmentation, distalization of molars, molar rotation correction, and then for space maintenance, by activation, by correcting the inner bow, we can create molar rotation. So again, it's in detail, it's a long thing, but I'll just brush up quickly. Space maintenance, headgear helps maintain the space arch length by preventing mesial migration of the molars. The limitations of headgear therapy is that patient compliance, unwanted dental changes, if there's any unwanted or unintended dental change occurring, then mandibular growth requirements, that is class 2 conditions, especially with prognathic maxilla. And then we have face mask or reversible headgear. This is used in class 3 conditions, class 2 malocclusion, where the maxilla is retrognathic with normal mandible and normal maxilla with prognathic mandible, and a combination of both. So reversible headgear has a chin cup, and then we have a forehead cap, and then we have elastics. Heavy elastics are used in such cases. So the anchorage site would be it derives anchorage from the forehead, that is a frontal bone, and from the symphysis region. So the force consideration is that it advances the mandible by 2 to 4 mm over a period of 8 to 12 months. And the factors influencing the protraction are forces of around 450 grams, that is 1 lb per side during mixed dentition. And the force direction is the downward pull at 15 to 20 degrees at the occlusal plane, ensures a pure forward maxillary translation. So frequency of use is 12 to 14 hours per day. The indications of reversible headgear are mild to moderate class 3 cases, cleft patients, to aid in selective rearrangement of the palatal shelves. And then post-surgical relapse can correct the relapse after osteotomies. And then we have incorporation of expansion screws with maxillary expansion used in adjunct with maxillary expansion therapy. So these are the components of a face mask, where you can see the forehead cap and the chin cup metal framework, and the intraoral appliance, where heavy elastics can be given. Again, low force, 250 grams per side, may take about 13 months to see the result, and high force of 1,600 to 3,000 grams can shorten the treatment time to 4 to 21 days. But again, the result is not stable. So an average of 8 to 12 months of wear is necessary for optimal results. So age of the patient, the ideal time to intervene is in class 3 it requires a very early stage when the upper central incisors first erupt, And then we have the positive overjet and overbite after face mask treatment can help maintain the anterior occlusion. So so in the primary dentition or in the early mixed dentition would be an ideal stage for this treatment. Length of the treatment duration range from 3 to 16 months. And then the most orthopedic changes occur within the first 3 to 6 months after the maxillary expansion. Prolonged use of protraction forces may result in the dentoalveolar changes. So these are the different types of reversible headgear which you can see. The first one is the protraction headgear by Hakim. And then you have the Delair face mask. And then you have the Tubinger model. And then you have the Petit type face mask. Since the time is very short, I would just brush it up. You can see the main points jotted over here. So these are the different types of face masks. So this is a chin cup, which was introduced by Oppenheim. The chin cup is used in class 3 malocclusion cases characterized by a protrusive mandible. So this much time we were seeing about the retrognathic maxilla or the prognathic maxilla. Now we can see about the prognathic mandible where we can control the growth of the mandible. So the chin cup assembly again has a chin cup, head cap, and the force modules. So we can custom or preformed chin cups are available. So we can go with the patient need, which is needed, we can go with it. Then typically an elastic strap or a metal spring connects the chin cup to the head cap, delivering a force of 16 to 24 ounce, that is 400 to 800 grams per side. The types of chin cups are occipital pull chin cup, vertical pull chin cup. So here again, you can see the occipital pull chin cup can cause lingual tipping of the lower incisors, and vertical chin cup causes, it's used in steep mandibular cases, and it causes counterclockwise rotation of the mandible. That is, it reduces the mandibular plane angle and increases the posterior facial height. So force magnitude and duration of wear, initially it is 150 to 300 grams of force per side is applied. Overall, following a 2-month period, force is gradually increased to 450 to 700 grams per side, with a wear time extending to 10 to 12 hours daily. The duration of use is increased to 16 to 18 hours per day. After that, the force is reduced to 200 to 400 grams per side. And then the appliance worn should be for minimum of 12 to 14 hours per day for optimal results. To stop the mandibular growth, a minimum force of 1200 grams, that is 600 grams per side, is required. To redirect the growth, we need a force of 800 grams, that is 400 grams per side is sufficient. So to conclude, the myofunctional and orthopedic appliances, they are the key appliances for correcting the malocclusion and guiding the facial growth. Myofunctional appliances addresses the functions like any improper habit or any other extraoral forces which cause. They guide the muscle forces to align the jaw or to align the dentition and redirect the jaw growth. So this is with the myofunctional appliance. And orthopedic appliances, they modify the growth by restricting the growth, that is in the maxilla or the mandible, to correct the skeletal structures in class 2 and class 3 cases. So headgear and face masks play a crucial role in the restriction of the jaw growth. So both these types are most effective when used in growing patients, with myofunctional appliances focusing on the functional issues and orthopedic appliances correcting more significant skeletal imbalances. Their success relies on proper diagnosis, timely use, patient compliance, offering non-invasive alternatives to surgery, and improving long-term dental and facial outcomes. I thank you all for having your valuable time with me. And if there's any question or anything, feel free to contact your sir. So thank you.